has happened. I okay. So Dr. Naresh Bhatt told us about at least the glimpses of NBI, and I'm going to talk about its practical utility in treatment of early cancer. So basically, how do we define early cancer? Early cancer is defined on four things. One is tumor histology, second one is depth of invasion, third one is tumor differentiation, and fourth one is lymphovascular invasion. So whether it's esophageal, gastric, or colonic, when you say it's early cancer, means that it's tumor with a malignant potential, but the depth of invasion is either mucosal or early submucosal. And early submucosa is defined separately for esophagus, colon, and stomach. And it should be well differentiated ideally, but may include moderately differentiate. But if it is poorly differentiation, probably it's not an early cancer. And there should not be lymphovascular invasion. So who would tell us about lymphovascular invasion? Only the pathologist can tell us. So you take the specimen out, send it to a pathologist, and they can tell you whether there was lymphovascular invasion. Of course, if you see it on imaging, CT scan or EUS, then definitely it is not an early cancer. So basically, when we say it's an early cancer, why it's important to differentiate or why it's important to classify early cancer is because we want to take it out endoscopically. We want to take it out in a minimally invasive way. And why early cancer is important to differentiate is mainly for the lymph node, we do it with lymph node metastasis. And And if you want to speak, Baila ત્યાં જતો રહે. So, how do we differentiate whether this patient has early cancer, no chance of, or very less chance of lymph node metastasis by variety of methods? And one of the important one is NBI. Of course, you can do chromoendoscopy. White light, we know that cannot, most of the times will not be able to tell us about early cancer. You can use EUS, but the scope what we use most of the times, except its colon or stomach, would not be able to tell us. You may have to use high frequency mini probe, especially in esophagus. Uh, so for us and for me, if I'm planning an endoscopic therapy or minimally invasive therapy, the most important thing is uh, chromoendoscopy, whether it's a virtual chromoendoscopy or normal conventional chromoendoscopy. Uh, Practically, it's NBI or equivalent other methods because it will tell you about whether there is some abnormality. It will not tell you about only there is abnormality, but it will also tell you whether it's probably benign or probably has a malignant potential. Once you have it, it also maps the lesion. Many a times the lesion is seen differently in a white light, but when you start chromoendoscopy or when you do an NBI, you would have actual mapping of the lesion. And of course, you would know about the deep invasion. Uh, how would you know, as Dr. Bhatt told us, if IPCL are abnormal in esophagus, they are uh, uh, not elongated, but they are spaced out, they are thickened. If there is loss of vascularity in a colon, if it is lesion which has surface which is irregular with amorphous surface, capillary pattern. So all these features would tell us that there is a submucosal invasion. Once you think it is a deep submucosal invasion, then probably it's not an early cancer. In a limited or if you have a dilemma whether there is a deep, and I'm talking about the word is deep submucosal invasion, then you can go ahead with ESD, but then it's mainly a diagnostic resection. And when you send it to a pathologist, the pathologist will tell you whether it's a curative resection or a diagnostic resection. I'm not going to go into detail, but you know that this is a Kudo pattern, which is there. Then there is Sano, which is mainly vascular. Kudo was Pete. Sano is vascular pattern, but the Paris classification for colon is uh, combining everything. And when you have lesion like this, where there is amorphous surface, the vessels are thick, or there is loss of vascularity, then you uh, should refer this patient for surgery. So let's take one by one. First, one is esophageal. Esophageal is the most delicate of all, because see, basically, uh, lymph node metastasis is determined mainly, of course, by the differentiation, but also by the depth of invasion. The most important thing in uh, lymph node metastasis is depth of invasion. And depth of invasion is different for all. It's definitely different for esophagus and colon. The reason is that in esophagus, you are safe only if the lesion is M1 and M2. So you have either the lesion in epithelium or lamina propria, then lymph node metastasis is very minimal. But once it goes into muscularis mucosa, so it's still a part of mucosa. So if the lesion has gone into deep mucosa, then also you have the lymph node metastasis going up to 18% in different studies. If it is a submucosa, then submucosa, if it is less than 200 for squamous and less than 500 for adenoCA, the lymph node metastasis risk goes up. So if you go for the deeper submucosal invasion, the lymph node metastasis is up to 50%, and for SM3 it is 60%. So it's a very high lymph node metastasis risk. So that's why in esophagus, or in that way in any place, knowing submucosal invasion before you plan your therapy is very important. You asked whether you take biopsy. You can take biopsy in stomach, because why you don't take biopsy? Because if you want to take out the lesion, when you are taking out, biopsy will cause fibrosis. So it's mainly seen in colon. Stomach, you are fine. Esophagus, we don't know, but still you can take biopsy. So it's mainly for the colon, you can't take biopsy. And I don't take biopsy. I just take it out. If you have a hyperplastic polyp, and if it is in the right colon rectum sigma, you don't have to do anything if they are less than 5 millimeter. If it's in the, except for the right colon, whatever may be the size, you take it out. As sir said, you keep your cold snare, and I do 90% of polypectomy now is by cold snaring. I hardly use hot snare. I use hot snare only for the pedunculated polyp. Even piecemeal EMR, many a times I do with cold snare. Uh, so small polyp, just take it out. As sir mentioned, serrated polyp, it's absolutely mandatory to look for serrated polyp, and they are missed. How do you see serrated polyp? Because they are not just like polyp. They have a smooth kind of surface. They are more like hyperplastic, but the mucus is sticking to there. So if you see some elevation with mucus, you have to probe that place and see whether there is a serrated polyp. So any polyp, you just take it out. Don't send it for pathology. I don't send it for pathology. But again, sir's point is valid that patients can ask, so what's the pathology? But otherwise, I tell my patient, you have a polyp. Of course, if it is a peduncular polyp, whether you take biopsy, doesn't matter. If you have a lateral spreading tumor, but lot of nodular component, then as sir said, I take tooth biopsy max. I don't take more than that, because even in that nodular component, lateral spreading tumor, when I am trying to take it out with ESD, I see a lot of fibrosis, even with 3, 4 biopsies. So take as minimal as biopsy. So for esophagus, only if it is early submucosa, you can go for endoscopic resection. Same thing this slide is saying, but remember for Barrett's it's a different thing. Barrett's, now you can do EMR, especially if it is less than 2. If it is more than 2 centimeter, still you can do EMR for Barrett's, but if more than 2 centimeter, and if it is malignancy in Barrett's, it's better to do an ESD. For squamous cell, uh, uh, the you are safe if the lesion is in mucosa, early part of the mucosa. That means muscular. If the lesion goes into muscularis mucosae, the lymph node metastasis starts. But still, you can do ESD, but no EMR. So esophagus and stomach almost always ESD. They want to do EMR. Esophagus, if it is a small lesion, if it is adenoCA, you are still better off if than squamous cell, because the reason is if there is a submucosal invasion, in squamous the submucosal invasion limit is 200 microns or micrometer. For adenoCA it is up to 500 microns. Beyond that you have a high chance of lymph node metastasis, and that's why it is absolutely mandatory to see for the submucosal invasion. In esophagus, you can tell about submucosal invasion, but we are more used to colon. Esophagus, you can make mistakes, uh, but you are fine because eventually you are going to send it to a pathologist and you are going to decide on what pathologist is saying. The frequent question, whether you do EUS, uh, uh, NBI is superior to EUS for early esophageal malignancies. So, and that is what this study also shows. So, almost always for early T1 lesion, I don't do EUS. It is, or you want to see for the lymph node. So, if you are suspecting, and if you are not sure that this is early lesion, mucosal lesion, then definitely do EMR or do EUS. I'll show you a case where we did EUS. We were not sure whether it's in the submucosa, but at least we were sure that it was not involving muscle and there were no lymph nodes. So at least those information is better seen on EUS, but otherwise NBI is better than EUS in esophagus for submucosal invasion. So you have to start this video. I can't do it from here. ખાલી આમાં હાથ કરે ને એટલે થશે yeah. So basically stop. Oh, ના આગળ થોડું આમ પાર્શિયલી સ્ટોપ કરે. Yeah, stop બસ બરાબર છે બરાબર છે. Sir, can you comment on this?
See, I think what we can clearly see on white light endoscopy itself, that there was an abnormal area that was a little raised.
Yeah.
That was clearly visible, so it was not a challenge picking up this lesion on white light endoscopy. And once you've found in white light endoscopy now, you want to confirm, yes, what is the IPCS, what is the depth of thing that you can see. And here, you can see at this end, you can see these IPCS. And in the esophagus, what we call them is A, B1, B2, B3. That's the classification of the Japanese society. And this will be, at best, showing A is normal, right? So this is not normal, it's a little more, so maybe inflammation or low-grade dysplasia, right? So this is certainly not malignancy. This may be inflammation and thing, and this is at the periphery. But if you concentrate, look here, you are not able to see too many. Here in this area, you are seeing definitely what is definitely B2. But if you come here, you're almost finding avascular areas. You're not seeing anything at all. And to me, this is worrisome and telling me that perhaps we're dealing with a little more aggressive, and there may be submucosal extension. This is what I can see. Maybe if you have some more
Yeah, it's
images.
just running that. So yeah, but I think this is what it is. I have bigger video, but
So remember that is whatever your NBI and other thing, your Paris thing tells you a lot.
yeah.
right? If you have nodular areas, see all your NBA, everything is good when you're talking about 0, 2A, 2B, flat lesions. The moment you have some depressed area, you should be suspicious that there is something more aggressive. And if you have nodular areas coming up like that, certainly you should be very, very careful before you sort of embark on any kind of ESD or whatever.
So basically, the biopsy was taken outside, and that